Perfect. All right, y'all. Well, thank y'all very much for joining another Emory Upshirt Grand Rounds. This Monday, we are very lucky to have somebody who doesn't need much introduction, but nonetheless is a close friend to many people on this call. So Jeff Yao from Stanford, he is a trailblazer in many ways in a lot of aspects of hand surgery, but especially in arthroscopy. Somebody I personally have looked up to and idolized as I've sort of begun my venture into arthroscopy, and somebody who's really kind of helped bring arthroscopy to America and really innovative in a lot of cool ways. So we're lucky enough tonight to have him teach us a bit about something that I think all of us have interest in and all of us can learn a lot more about. So thank you, Jeff.
Awesome. Thanks, Eric. Thanks for the kind introduction, and thanks for the kind invitation to spend this night with you guys. I know it's really late out there. I'm impressed that you got the attendance that you have. All of our trainees turn into pumpkins around 5 p.m. So it's good to see everybody on. And I appreciate, again, the invitation to participate. I want this to be interactive. I can drone on and on about this stuff for hours, as you probably can tell, but feel free to interject at any point, ask questions at any point. I have a ton of slides, so I'll go relatively quickly, but again, I'm happy to stop at any point to answer any questions that you may have. Sound good?
Perfect. Thank you.
All right, so I'm going to share my screen. Let's see. Can you see that? Is that in presenter mode and or regular mode for you?
That's presenter mode.
Okay, let me
212, yeah.
There you go, perfect.
No, that's too many slides. 212, that's too many.
I'm telling you, I could talk about this for hours. Okay, but I'll speak relatively quickly, and we don't have to get to everything, but I thought I'd do a smattering of kind of what I think are my best indications for wrist arthroscopy. Okay, so again, I want to thank Eric for the kind invitation to participate. I think wrist arthroscopy has been a big part of my practice. I think it's part of his as well. We have Christoph Matulin, who's the bald gentleman in the middle of the screen, middle of the photo on the left-hand side, to really thank for really pushing wrist arthroscopy. It really was popularized in the 80s, but didn't really catch steam until our colleagues in Europe and Asia really took it on and took it to the next level. And it's sad to say that we're actually, I think, behind our colleagues in the other parts of the world when it comes to arthroscopy. But hopefully, through the efforts of Eric and other young, ambitious surgeons around the country, that will be changing. So this is a near and dear topic to me. I like this slide because I'm constantly updating it, but wrist arthroscopy is a niche thing. And I encourage for the trainees on the call, whenever you get out into practice, is really try to become an expert in some part of upper limb surgery, whatever that may be, because it will take you places. These are just some of the places, I mean, all the places that I've been to talk about wrist arthroscopy over the course of the last few decades, last few years, I should say, a couple decades. But this is and I've been blessed in that I've met a lot of great people, learned a lot of incredible things from people all around the world who share a common interest, which is wrist arthroscopy. So just for some background, again, it was first described in the 70s, but really not popularized until the 80s. And it was really Terry Whipple and others, Gary Paling, others who really popularized it in the US. The indications have really grown in the past several decades. First, starting off as being diagnostic. It's been shown in a number of studies to be more accurate than CT, MRI, and arthrography. But also the therapeutic indications have grown significantly over the course of the last few decades. The potential benefits are smaller incisions, less dissection, earlier recovery, return to work, and greater patient satisfaction. In fact, if you look at PubMed, I just searched this last night, you could see the number of publications over the course of the last several decades is just really ballooned. When we talk about therapeutic indications, there's a number of things that you can do arthroscopically. All of these things have been described. But if you look at some of these things, particularly down towards the bottom, salvage procedures, PRC, distal scaphoid excision, four-corner fusion, etc., This can be done and has been described arthroscopically, but you have to wonder at a certain point, is there a triumph of technology over reason? So for me, I'd like to share with you tonight my current best indications. I think these are the most common things that I use arthroscopy for. I do it for other things, but I think this is the most commonly, or the best indications, I should say, for wrist arthroscopy. For those of us who are new to arthroscopy on the call, this is the typical setup that we use. We use traction. There's a number of different traction towers that are available. I have no financial disclosures relative to this, but any traction on the limb to open up or distract a joint is useful. These are the portals that we use, and they're named based on their location relative to the extensor compartments. And so 3-4 would be between the 3rd and 4th compartments, 4-5 between the 4th and 5th compartments, 6R is directly radial to the 6th compartment or the ECU, 6U on the ulnar side, et cetera, et cetera. I do have some tips and tricks throughout the talk, and they're highlighted in red here. And so my first tip is for the orthopedists on the call. You know, when we're used to making portals for shoulder arthroscopy or knee arthroscopy, we take that 11 blade and we just kind of plunge it right down through the skin and sometimes right into the joint. You don't want to do that when you're doing wrist arthroscopy. We have a lot of important structures. You got tendons in there, you got nerves in there, you got blood vessels in there. So you don't want to do that blindly. So I just nick the skin with my blade, and then I use my a small clamp to spread. My fellows always tell me that they have nightmares when they go home, just hearing me whisper in their ear, spread. And the point is that you just spread past all those important structures, and then you get down to the capsule, pop in, and it should be really easy. You shouldn't have to push hard. If you're pushing too hard, that means you're bumping up against one of the bones or one of the tendons. We also have some mid-carpal portals, and there's a number of mid-carpal portals that we use. Also thumb CMC portals if we're looking at thumb CMC arthroscopy. And the point here, the next tip is make sure that you're aware of and use your accessory portals liberally because they can help you, particularly if you're in a bind, if you can't see around the corner. There are a number of portals that have been described that can help you gain access to the individual nooks and crannies within your wrist. My next tip is what I like to call the poor man's arthrogram. We described this a few years ago. And what I like to do is I do wet arthroscopy. I'd love to hear Eric and others on the call what their preference is. But I do wet arthroscopy for most of my arthroscopies. And so part of that is we insufflate the joint. And we insufflate the joint with saline. And when we go in through the 3-4 portal, we like to expand the joint and see whether or not the fluid traverses from the radiocarpal joint into the midcarpal joint or into the distal ulnar joint. Remember, there's 3 joints primarily in the wrist, and so if you're injecting saline into the radiocarpal joint and the fluid traverses into one of the other joints, you know there's a communication, and you know that there's either an injury to your intercarpal ligaments or your TFCC, respectively. No, we did this study that showed that the radiocarpal joint takes roughly about 3.5 cc's of saline in a normal sized patient. So if you're injecting 6 cc's and it keeps going, that means you probably have some communication with one of the other joints. My next tip when you're doing diagnostic arthroscopy is like a pilot. I like to think of the arthroscopist like you're like a pilot. You know, when a pilot gets in the plane, they do their pre-flight checklist. They have a bunch of things that they want to check before they even fire up the engine. And so you check all your instruments. You want to make sure your scope is good. It's white balance. There's no scratches on the lens. You want to make sure the scope is focused. If you're doing wet arthroscopy, you want to make sure your inflow is ready. It's primed. And you have outflow if necessary. Time and time again, one of our trainees, we get into the joint and they're so excited they're in the joint, they start going in random directions, kind of ram shot and trying to look at everything all at the same time, which I get it. You're excited, you're in the joint, you know, it's a victory, but you want to make sure that you do it systematically, just like when you do a knee arthroscopy. It's been a while for me, but you start off in the patellofemoral joint, then you go into the medial compartment, then you go into the lateral compartment. Same thing for me. I like to start in the center of the wrist, then I go radially, and then I go ulnarly. And these are the sequence of ligaments that I like to see. throughout my wrist arthroscopy, and I like to take photos of everything so that I know that 10 years later, if I need to look back at a photo, I know the third photo is this structure, the eighth photo is that structure, and it's the same sequence every single time. And then you know you won't miss anything. So this is what a typical radial carpal arthroscopy is. So we have our scope in the 3-4 portal. This is wet. And you can see the first thing we see is the ligament of testute, also known as the radioscapholunate ligament right there. It's kind of like the ligamentum mucosum in the knee. It covers the short radiolunate ligament and points to this next ligament, which is a scapholunate ligament. The scaphoids to the left, the lunates to the right. And then directly to the radial side of testute is the long radiolunate ligament, this big, broad ligament right there. That's the strongest ligament in the wrist. And what I'm probing at, that space in between that and the next ligament, the radioscaphocapitate ligament, is the space of Poirier, or the weakest part of the capsule. So the strongest part is right next to the weakest point. Then this is what I like to call the hamburger sign. We got a hamburger bun above this lunate, the hamburger bun below, which is the lunate facet. And those are your ulnar extrinsic ligaments, your ulnar lunate and ulnar triquetral ligaments, which is a big, broad set of ligaments. Then we go over to the TFCC. You see the articular disc there. I'm probing it. And then I'm looking for a tear. And in this particular case, you can see the synovitis and the tearing of the peripheral TFCC, which is pretty classic for a TFCC peripheral tear. And that's kind of the first look of your radiocarpal arthroscopy. Once you get into the midcarpal arthroscopy, this is with the scope in the radial midcarpal portal. You can see the capitate is above, the scaphoids below, to the left, right there, and the lunates to the right. You can see the cleft in between the two. Normally, you should see a nice tight cleft between the two bones. If that's loose or there's a step off, then that's indicative of some instability. I follow the scaphoid up distally into the STT joint. So there's the trapezium. And then there's the trapezoid, and behind that, there's the trapezium. So you see the scaphotrapezial trapezoid joint. Then I come back down, the scaphocapitate articulation right there, follow the capitate. I'm seeing the lunate right there. The capitate's articulating on the lunate. There's a small additional facet there off the lunate, so type 2 lunate there. You can see the hamate in the back there. There's a lot of synovitis here, so it obscures our view. The needle's pointing to the hamate there. And then lastly, there's the triquetrum right about 1 o'clock. So that's what a normal midcarpal arthroscopy would look like. Okay, so let's talk about some of the pathologies that we treat. So one of my favorite things to treat arthroscopically are dorsal wrist ganglions. I always like to show the slide. Who wants this when you do an open ganglion, when you can have these nice cosmetic portal sites? I'll be honest, I hate doing open ganglion excisions. You're digging in a deep hole. You're trying to make a cosmetic small. I prefer a transverse incision, all joking aside, and they heal quite fine. They heal well with an open incision, but it's a big, deep hole. I don't like digging into big, deep holes. I'd much rather do this arthroscopically. So it was described by a number of people. Lee Oshman, Marco Rizzo, Scott Edwards have published on it with the published recurrence rates up to 12%. The benefits: potentially improved early range of motion, is more cosmetic with earlier recovery. You can avoid iatrogenic injuries to the scapholunate ligament. Sometimes people are digging around in there trying to get it off the scapholunate ligament, and they'll actually transect or at least injure the scapholunate ligament. You can protect that, and I'll show you how to do that arthroscopically. And then, as with anything arthroscopically, you can also evaluate for other intra-articular pathology. And this has been seen in up to 42% of patients with ganglions. So the key to arthroscopic ganglion excision, and quite frankly, open excision as well, is you want to make sure you identify the stalk. I tell people it's like taking care of weeds in your garden. You don't want to just cut the weed, because if you leave the stalk or the root, it's just going to grow right back. So you want to take it out by its stalk. And then you shouldn't have recurrence. But sometimes you can't see the stalk. And this is, if you look in the literature, the stalk is seen anywhere from 9% of the time to 100% of the time. And when you see a spread like that, generally, you're not seeing the stalk. It's pretty inconsistent how often you're seeing the stalk. So I could say myself, I see it distinctly, probably less than 50% of the time. So you're going in there, you're trying to excise it, but you can't really necessarily differentiate it from the surrounding soft tissues. So this is my next tip. This is a paper we published a few years ago where you can inject this stalk, the cyst percutaneously with methylene blue or indigo carmine, and that lights up the stalk. And so I'll show you this in a second. So here the scope is in the 6R portal, and you can see the cyst. I'd like to draw a nice circle around and make sure I can identify it after the prep and drape goes. And you can see I'm injecting indigo carmine percutaneously right into the cyst. And what that does is it'll light up the cyst. So here's a typical arthroscopy setup. You see the portal is marked out there, 6R and 3/4. The ganglion is marked out there. And this is what it looks like. Again, now coming from the 6R portal, you can see the lunate above, the scaphoid's in the background, the scapholunate ligament's right there. So I find my scapholunate ligament. I follow it up dorsally. There's ubiquitously always this capsular flap or frond-like stuff, always dorsally. With any ganglion, and that gets caught in the wrist when they hyperextend the wrist, the so-called dorsal wrist impingement syndrome. And so that can be painful, particularly with wrist hyperextension. And in this case, it looks like maybe there's a thickening of the dorsal scapholunate ligament right there. Okay, maybe that's a stalk, but let's see. So this is another example just to show you what it looks like. Here, you can clearly see what the stalk looks like on this specimen. So you don't necessarily need the methylene blue on this, or indigo carmine, but here you can see once you inject it, it lights up nice and blue. So that can help guide your exposure. So here's that case again where we injected. We're looking, we can't really necessarily see the stalk, and as I inject, you can see it lights up blue, and that helps guide you to identify where the stalk is, so that when you start excising it, you know exactly what tissue to remove. So then the rest is pretty easy. You just create your 3/4 portal. You get your shaver in there. This is a 3/5 shaver, and you just amputate the stalk right off the scapholunate ligament. Just cut it off at its knees, so to speak. You can see in this case, right there's the lumen where you can see the blue coming out, and that's where I'm amputating it from the scapholunate ligament. So let's see. I'm sorry, this is not playing, but you get the idea. It's not rocket science. You just go in there and you just amputate it at the stalk level. And that's all you need to do. And then once you're done, you can see the scapholunate ligament. This is what I was talking about before. You can protect the ligament by putting the back of your shaver up against the ligament so you don't inadvertently shave the ligament itself. Postoperatively, I just put them in a soft bandage for 4 days, and then we let them basically use their hand. Normally, I use dissolvable stitches now, so they don't even have to come back for suture removal. We just let them fly. We published on our experience with the dye. We did visualize our patients, 27 patients with the dye in every single case. We did have recurrence, and interestingly, the recurrence was with the so-called occult ganglion, the ones you can't see at the skin level, but you can see on MRI. So for that reason, I tend to still treat the occult ganglions open, because we can't benefit from the methylene blue trick, because when you have to be able to see it at the skin level in order to be able to inject it. And so then it's kind of a coin flip whether or not you're actually getting it. You go in there, you shave off the ligament, and you're hoping that you get the occult ganglion. So when there's an occult ganglion that's identified on MRI, and the patient has pain, I typically will go in there via an open approach. What about intercarpal ligament injuries? Kind of in the same genre. You can argue that the ganglion is sort of the first step of developing a scapholunate issue. And so the next tip is the so-called bubble test. And so, I'm sorry, this video is not playing either, but basically what this is showing is I'm injecting air into the midcarpal joint, and then I'm putting the scope into the radiocarpal joint, and I'm seeing whether or not bubbles go from the midcarpal joint into the radiocarpal joint. So it's kind of like that poor man's arthrogram test. And if you see air going through, then you know there's some communication from one joint to the other. So you inject one from one side and one to the other. I won't go into all the details of scapholunate ligament injuries. Hopefully everybody's familiar with those. But when we talk about treatment, we talk about the Geisler classification, and the Geisler classification, we treat them with debridement, with or without thermal shrinkage, up to grade 3. Then we add some pins if it's grade 3, and grade 4, then you're looking at either an arthroscopic capsulodesis, which I'll share later, or an open repair if that's what you feel more comfortable with. So just a quick word on shrinkage. I know it's very controversial. The thought is that by shrinking the collagen, it leads to restoration of stability. There's secondary fibroplasia and scarring, and I do think there's a denervation effect as well. So this is our next tip. This is how it works. Remember, collagen's made up of 3 collagen fibrils, which are wound in a triple helix, and they're linked by covalent bonds. And there's 2 types of covalent bonds: heat labile and heat stable. When the collagen's treated with the tissue heating, the heat labile bonds are disrupted, but the heat stable bonds are intact. So what happens is it leads to a net shrinkage of the collagen fiber. I tell my patients, kind of like taking a piece of meat and putting it on a grill. And what happens? It shrinks, right? So same kind of situation. Then over the course of 6 weeks or so, and this is all from the sports medicine literature, after about 6 weeks, those heat labile bonds restore themselves, and then this structural strength is restored to the collagen fiber. We showed in our lab that we also think there's a denervation effect of using the heating probe. So what happens is you could see in the area that's been treated, there's an obliteration of neuronal markers. And so we think that that contributes to why patients feel better after this treatment as well. So this is what it looks like before and after the thermal treatment. You can see the frond-like fluffiness, and then it looks a little bit tighter after the thermal shrinkage. And if you have a higher grade injury, grade 3, then you stabilize the bones together with 2 K-wires and then do the thermal shrinkage. And here's a case of that before and after the bones are pinned together, and then the thermal shrinkage. And we published on our results of 9 patients with up to grade 3 with a mean 7-year follow-up. So the longest follow-up in the literature. There's a number of other studies that have looked at this, but ours is the longest follow-up. And you can see the outcomes measures are quite good. And most importantly, 0 of these patients required subsequent surgery. So their pain was resolved, and they were able to return to activity. Let's say you have a higher grade injury, guys, so grade 3, you could treat this with the thermal shrinkage and pinning. But what I've been doing now is a capsuldesis procedure. It's described by Christophe Matulin, who I showed earlier from France. And this is based on the concept of the dorsal-capsulo-scapholunate septum, or DCSS, being an important stabilizer or secondary stabilizer of the scapholunate interval. And the thought is that by performing a capsuldesis, bringing that tissue back down to the scapholunate interval, that helps stabilize the interval. So this is how it's done. Basically, in cartoon form, we put needles through the 3-4 portal, up through the midcarpal joint, up through the radiocarpal joint, up through the midcarpal joint, through the remnant of the ligament. We put one on either side, and then tie a knot on the outside of the joint and bring that back into the joint, and that closes the capsule back down to the dorsal scapholunate ligament. And I'll be honest, when I first saw this, I said, no way this is strong enough to maintain the stability of the scapholunate interval. But after doing this now, I don't even know how many times, and seeing it happen in real practice, it's impressive how strong and how useful this technique is. So here's an example. So here's that patient with that grade 3 injury. So here, hopefully this video will play. Good. So we could go in through the 3-4 portal here. We're going up through the ligament. You can see the ligament's largely intact. So we're going up through either side with each needle. Now you can see the 2 needles in the midcarpal joint now. So the scope's in the midcarpal joint, and now we have the suture passed from one to the other. We come out and tie a knot. Hang on, let me show this video. So we bring both limbs outside the joint, tie a knot, and then pull them back in. And you can see, just by pulling on the suture, you can see how that reduces the scaphoid back to, or the lunate back to the scaphoid. Let me play that back again. So here's the 2 strands. I'm pulling the needle, this knot in, and you can see just by pulling it, it draws the lunate back to the scaphoid. And here you can see before and after. Let me play this video again a little bit further on. You can see there, you can see I'm taking tension off the sutures, and then I'm demonstrating where it's open. Then I pull on the sutures, and you can see loose. It's loose there, and then I'm going to pull on it again. Now I'm pulling on it, and I'm trying to put the probe back in there. I'm pulling on it, reducing the interval, and you can see trying to get the probe back in. It doesn't go in. So it's remarkably strong, this technique. So there's it before when it's open and after when it's closed. So for these patients, I put them in a cast for about 6 weeks, start therapy at 6 weeks, return to full activity at 12 to 16 weeks. And this is based off of Christoph's paper, 36 patients. Grip strength was about 92% of the contralateral side, and you can see their outcomes were quite good. Moving on to the TFCC, this is another great entry drug, like the ganglion, for getting into wrist arthroscopy. These are easy injuries to treat arthroscopically. Maybe the scapholunate ligament is a little step up in terms of technical challenge, but these are easy things to treat arthroscopically. In fact, I would argue that the standard of care now is to treat TFCC injuries arthroscopically. So the classification, this is Andy Palmer's classification from 1989. There's a number of different classifications that have come since, but this is the classic classification. He bases it on whether it's traumatic or degenerative, and the traumatic tears are subclassified based on their location. 1A being central, B being peripheral, C being volar or distal, and D being a radial avulsion. So when we see patients with TFCC injuries, we obviously want to take a good history, clinical findings, and use studies to formulate a plan. Non-operative is always still the initial treatment, unless there's gross DRJ instability. So we showed in a paper that if you immobilize a patient for 4 weeks with a cast or a splint, that 57% of those patients ultimately required no further intervention. And the thought there is that peripheral tears do have the ability to heal given their vascularity if they're immobilized. But 57% isn't awesome. That means 43% ultimately did succumb to have something further done, whether it be surgery or something else. So if that fails, the immobilization fails, then we talk about steroid injection. And if all fails, then we're looking at surgical intervention. And that it depends on the location of the tear, whether or not it's debridement versus repair. So central perforations are some of the most common we see, traumatically or degenerative tears. These are unlikely to heal. It's like the white zone of the meniscus. It's avascular, and so there's no healing potential. Whoops. So they may be debrided, and biomechanical studies have shown that up to 2/3 of the disc can be removed without affecting load transfer. And you see this more in patients with ulnar positive variants. And in that case, you may consider an ulnar shortening osteotomy or a wafer procedure at the same time. The debridement is very straightforward. It's just like a meniscus debridement. In the interest of time, I'll just pass through this, but basically just put a shaver in there and trim it back to a healthy, stable rim. I do like to use the thermal treatment on this as well. You can see what happens when we tighten up the ligament here. I don't think this provides any real structural stability, but I do think the denervation effect is real here. And I think this helps in terms of the patient's pain relief. I don't think it's necessary, but I do think it's helpful. Here's that denervation effect again. So this is what it would look like after a final debridement. Sometimes you have to take a pretty reasonable swath of the tissue away to make sure you get back to healthy tissue. And there's the ulnar head down below.
Jeff, question for you. This is Mike Gottschalk.
Hey, how's it going?
Sorry to interrupt, but which RFA probe do you use? We've had a hard time getting them from cost perspective for our ASCs.
Yeah.
And they're, depending on the size, there's only a few companies that make them.
Yep. Yeah, great question. And in fact, we were talking about Arthrex earlier before we started. This is a Smith & Nephew. It's still called the TAC-S probe. I don't have any financial relationship with the company. Just to give you some historical perspective, this was originally designed by a company named Oratech, and it was designed for thermal shrinkage of the shoulder. As you may remember, back in the days, in the 90s and 2000s, thermal shrinkage of the shoulder glenohumeral joint, the capsule, was very popular for multidirectional instability. And what ended up happening is it caused traumatic ruptures of the capsule. So it fell by the wayside. We could talk about the differences between that and the wrist. The reason I think it works in the wrist is because we can immobilize the wrist as opposed to the shoulder. You can't immobilize the shoulder for 6 weeks to allow that collagen to mature, and so that's why it would fail catastrophically. but all the development came from the sports guys, the shoulder guys who developed this probe, this specific probe for use in the shoulder, and it's fallen by the wayside in the shoulder. But thankfully, they made one small enough for use in the wrist, and it's designed. This is the one probe that I am aware of that is designed specifically for thermal shrinkage. A lot of the other probes that are out on the market are designed for ablation or coagulation, and neither of those have. And I don't really understand the physics enough, but neither of them are really designed appropriately for thermal shrinkage. And so, again, I have no financial relationship with this company, Smith & Nephew, but this is the Smith & Nephew TAC-S probe, which to my knowledge is the only one that's definitively designed for thermal shrinkage.
Jeff, if you don't do wet arthroscopy, is this one that can still work? You know how some of the ones in the elbow and shoulder require the saline? Is this, will this one work outside of wet arthroscopy, or is it only for what, like the shoulder and
Yeah, great question. So I would not use this in dry arthroscopy. I don't know if it works or not, but the heat that it generates, you want to have fluid in there that's constantly cooling it. It's hooked up to a monitor, which helps determine the temperature within the joint, and you'll see it rapidly goes up when you're using this probe, and probably any other probe for that matter. And as you know, at 60 degrees Celsius, that's when you start to have chondral injury. And so if your probe is going over 60 degrees Celsius for long periods of time, you're risking chondrolysis of the surrounding bone. So that's why I definitely do this under wet arthroscopy to help cool that. And then you use it judiciously. I kind of pump it once in a while. I'm not holding the button down pedal to the metal the entire time, because you'll see how quickly it spikes in terms of the temperature.
Yeah, I essentially have to go, just so you know, I have to go to a hook probe, which is a little bit larger, but essentially a similar thing, like a hook probe for the shoulder, just because that's all we could get them to bring in, because we had a big issue with getting the smaller probes. But the same thing, I just kind of use it very small, but normally for central tears and for type 1-2 SLs, as you showed.
Yeah, great. And been having good results?
Yes, I actually think that it works great for those. Because I think part of it's just that it denatures the stuff, as you showed, and I think gets rid of the pain endings.
Absolutely, I agree. All right, moving on. Thanks for the great questions. Keep them coming. So moving on to the 1C tears, I'm going to skip the 1B tears and come back to those. But the 1C tears, these are the distal tears or the volar avulsions. These are somewhat controversial. A lot of people don't even believe that they exist. I'd love to hear what our colleagues who trained at the Mayo feel about it. But Dick Berger, the late great Dick Berger, one of my personal idols, described the ulnar extrinsic split tears. And I can tell you, I've tried to repair a handful of these in my career. As the saying goes, probably a lot more of them saw me than I saw of them. But that being said, if you want to repair these, you want to make sure that you're doing it in a safe manner. The ulnar neurovascular bundle is directly behind those ligaments, and so you just want to make sure that you protect those. When it comes to 1D tears or radial avulsions off the radius, this was historically relatively controversial to debride or repair, and there are repair techniques that have been described. The thought is, however, that simple debridement has satisfactory results. In fact, when I was a fellow in Philadelphia, we did a study looking at those repaired and those who were debrided. And as long as there's no instability of the distal ulnar joint, we found the debridement to be quicker to perform, lower rate of complications, easier and faster to rehabilitate. Patients return to function sooner, and the results were equivalent to that of the repair patients. So in my hands, unless there's DRJ instability, I just debride my palmar 1D or radial sided tears. Now going back to the 1B tears, these are the peripheral avulsions. These are different. These are the red zones for those of you who are familiar with the meniscus anatomy. It's the same kind of anatomy for the TFCC. Most of the vascularity comes from the periphery, and therefore it's richly vascularized and has the ability to heal and is more amenable to healing. It's important to say, as good as Dr. Palmer's classification is, he lumped all peripheral tears together, and more recent literature and work has shown that, in fact, the peripheral attachments of the TFCC is really broken into two: the foveal or deep insertion and the styloid or superficial insertion. And either one of those or both could be injured. And so this is Andrea Atzai and Riccardo Lucchetti, who described their classification based on whether or not it's the deep portion, the superficial portion, or both that are disrupted of the TFCC attachment. So most of the patients that you'll see are patients with ulnar side wrist pain. They hurt themselves playing tennis. There's no instability, and they have pain in the ulnar aspect of the wrist. They have a fovea sign, TFCC grind sign, etc. So these are the class 1, where it's the superficial portion that may be torn. In this case, the DRJ is stable. In this case, a number of different techniques that can be employed to repair this, including open repair. A bunch of arthroscopic assisted techniques have been described, as well as all arthroscopic techniques. I think there are some disadvantages to the arthroscopic assisted techniques with extra larger incisions, prominent suture knots that are tied on the ulnar aspect of the wrist, which are very irritating for patients. Sometimes you could tie it over a button, but patients don't really tolerate those as well. And there's a concern for possible weaker repair with a monofilament suture as well. And so that led me down the road to my next tip, which is using this device, which was initially described for meniscal repairs in the knee. Again, I have no financial relationship with this company, but we thought, okay, the TFCC is an analogous structure in the wrist, so why not use the same device? It's an all-inside arthroscopic technique with 2 PEEK blocks with a pre-tied suture in between. And so basically each block is deposited on either side of the tear. And then as you cinch the pre-tied knot, it draws the articular disc to the ulnar capsule and closes the tear. And so we described this technique over a decade ago. These are the standard portals. The 3-4 portal is our working portal now. Our 6R portal is our viewing portal. Here you can see the scope in the 6R portal. This is on a cadaver, but you can see the device coming in via the 3-4 portal. In this particular case, I use the scope in the 4-5. You could do either or. And here that's the instrument. It's a delivery device. It comes in through the 3-4 portal. You can see the tear and the periphery. Hopefully I got a better view of it right out there. You can see how the articular disc is pulled away from the articular capsule. So I march back about 2 millimeters and I insert my introducer needle through the articular disc and then out through the ulnar capsule. Then there's a deployment trigger that pops through on the ulnar capsule like an endo button style. And then I go on to the other side of the tear. And so this makes a vertical mattress suture configuration. And this is basically unedited video, so you can see it's not a very short, not a very long procedure to do. And here I'm just popping through the ulnar capsule alone, and so now you have a vertical mattress stitch. You pull on the suture, and that draws the articular disc down to the ulnar capsule. You can see it closing that gap. And then there's a knot pusher that also doubles as a cutter, and so it cinches the knot further and then cuts the suture. You can see that space is completely closed now. So here's what it looked like pre-repair. You could see it's really soggy, boggy. There's no turgor to that articular disc. You could see where I'm pulling the attachment away from the capsule. And then here you can see after it's repaired, the amount of tension on your suture, which I can't get with a standard outside-in type technique. And then you can see as I bounce off the articular disc, you can see the amount of turgor that's been restored to the articular disc. So we published on our mean 7-year follow-up with this technique, 11 patients. And you see the benefit, the patients all did quite good with their dash score being significantly better than pre-op. And I think the benefits of this technique are, number one, it's fast. You saw it took about 1.5 minutes to do. You remove those prominent suture knots or button on the ulnar aspect of the wrist. No extra incisions are needed. We showed in some cadaveric studies to be safe. The closest structure to the device, which was the dorsal branch of the ulnar nerve, was just about 1 centimeter away. And we found that the strength of the repair in biomechanical studies to be superior to that of the outside-in technique. And so that has really reduced my immobilization. Typically for TFCC repairs, you put them in a long arm monster cast for about 6 weeks and then switch them switch them down. You can imagine being in a Munster cast for 6 weeks, how painful that is. So I just put them in a short arm splint for 2 weeks. And my colleague, Glenn Gaston from Ortho Carolina, does the same technique. He doesn't immobilize his patients at all. He just puts them in a soft dressing and lets them go. I haven't been that bold yet, but so I still put him in a splint for 2 weeks. But if he's getting good results with that, then maybe I don't need to immobilize my patients as well. So you can imagine being in a long arm cast for 6 weeks versus no immobilization, what the benefit to the patient may be from a quality of life perspective. What about foveal repair, a foveal tear? So this is the hook test. If you get in there and you're lifting your articular disc off the underlying ulna, you can see I'm lifting it up, the so-called hook test. And we also have, people call it ghost sign. Here's a ghost sign where I'm lifting up underneath it. Then you know the peripheral attachment or the foveal attachment has been disrupted as well. And in that case, a standard peripheral or a capsular repair that I just showed won't be sufficient, because you really need that foveal attachment to maintain the stability of your distal radial ulnar joint. And so that's when I think DRJ arthroscopy is useful. I do typically do this dry, and one of the smaller scopes is beneficial to do this. So I basically get into the distal radial ulnar joint portal. The ulnar head's below us, the TFCC is above, and here it looks okay. It doesn't look so bad, but as we move a little bit more volar and ulnar, in a moment you'll see a big hole. And I tell people it's kind of like doing a shoulder scope, and you're looking at the supraspinatus as it comes down to the greater tuberosity. There should be nice decussation of fibers, and you can see there's a big hole where we have our foveal detachment. So in this case, this is a class 2 or 3, depending on whether or not the superficial portion is disrupted as well. Here, in this situation where the foveal attachment is disrupted, you're concerned about instability of the DREJ. And for this, I like to do a foveal repair, and there's a number of different techniques you could do. You could do it open, you could do a transosseous, transstyloid. I like to use what's called the ulnar tunnel technique. So I make a small incision about 1.5 centimeters proximal to the ulnar styloid, right along the subcutaneous border of the ulna. And I spread down right to the ulna, protect your dorsal branch of your ulnar nerve. And then I put a little C-clamp targeting guide. The tip of it goes through the 6R portal. And then it goes right onto your articular disc. Then I put the targeting sleeve right along the ulna, and so that puts my guide wire exactly where I want to put it. So I drill my guide wire through the ulna, directly through the foveal attachment, and you could go through the articular disc, as you can see in the below photo. This is a 3.5 millimeter cannulated drill, so that's drilled right up through the ulna. But here you don't want to go through the articular disc, so you just go through to the fovea and then stop, and then the wire backs out. Then you put your needle that has whatever suture you want. This happens to be a fiber stick. It goes through into the joint. You pass one pass through here, and then you pass another one with a nitinol loop in a different location. And then once you have that through, then you pass your suture outside of the joint with the nitinol loop, pass the suture through the nitinol loop, and then pull the nitinol loop through, and that will set your mattress suture back down. Here you can see shuttling the suture. And then once it's down, you can see the amount of tension that you can get on that. As I pull on the suture, you see how it just buckles it right down to the fovea right there. And then after that, then you just put an anchor into the ulna, and that here it happens to be a push lock anchor, and that stabilizes your tension. And afterwards, you can probe your repair. It looks like a perfect mattress suture. You can probe it. You can see how puckered the articular disc is after it's been repaired. And you can see now I can't get my probe underneath the ligament here. And at the end, you always test your DRJ stability, make sure it's nice and stable after your surgery. What about ulnar impaction syndrome? This is another thing where I think arthroscopy can be useful. Here's a classic case of an ulnar positive variant with some edema within the lunate and triquetrum on MRI. I'll be honest with you, I'm not a big fan of the wafer procedure. This can be done arthroscopically by removing the articular cartilage of the ulna to offload the impaction. I tend to prefer the ulnar shortening osteotomy. Obviously, that can't be done arthroscopically. But there are some limitations of ulnar shortening osteotomy with hardware complications and potential for non-union. So I would submit to you that microfracture might be a good surrogate for either of those techniques. We're familiar with it from all the work that was done in the knee, but nobody really described it in the wrist until recently. The thought is that you debride the bad cartilage and then you debride the subchondral plate of the expose the subchondral plate of the lunate, and then microfracture through about 2 millimeters or so, allowing blood to egress out and form a clot. So here's one of our patients that had a big osteochondral defect. You can see that there. And so we debrided the loose cartilage, put our probe in there, our microfracture all, mallet it down, and then we let the tourniquet down, turn the fluid off, and you can see the blood coming out of the microfracture sites. And that clot over time will create fibrocartilage, not articular cartilage, but fibrocartilage. And in fact, we were able to look back at this patient 5 years later. She had a different problem, so we took the opportunity to look back at the lunate, and you can see it's resurfaced. It's not hyaline cartilage by any means, but it's definitely better than that big pothole that the patient had before. And we presented and published this on a small cohort of patients. The best thing is that none of these patients ultimately required a secondary procedure. So this might be an option for patients who might not be ready for an ulnar shortening osteotomy. I know we're getting short on time, so I'm going to try to fly through some of these other slides, leave some time for some questions if possible. So here's CMC arthroscopy of the thumb. I think it's very useful for treatment of Bennett's fractures. Obviously, you can pin them percutaneously using fluoroscopic guidance. I think that's totally fine. But I would submit to you doing it arthroscopically can help. You can visualize the articular surface and really help maintain the reduction as you're pinning it. Here are the standard portals on either side of the first dorsal extension compartment, as well as the thenar portal. When you first get in there, it looks like a bloody mess initially, but you clean it out with a shaver. And then now you can see the step off, the Bennett's fragment in the back and the rest of the metacarpal in the front. So now you can see with your typical reduction maneuver, you can reduce it. And then while it's reduced and you can watch the reduction, then you can put your K-wires in to help stabilize it. So arthroscopic assisted Bennett's treatment. For thumb CMC arthritis, it also can be used. If you believe in the HDA concept, you just remove the bone-on-bone pain generator. There's a number of people have published on thumb CMC arthroscopy with this potential benefit of shorter recovery, no bridges burned, as opposed to a typical LRTI or other more major CMC procedure. Same portals we're using here. We often identify a significant synovitis. We go in there and clean that out with a shaver, not too hard. You can see it's a big space. A lot of people get intimidated thinking the thumb CMC joint's a really small joint and you can't get the instruments in there. This is a 3.5 millimeter shaver, so you can see how much space you have to work in there. So the next step is to burr it down. It's like a chromioplasty in the shoulder. It's not rocket science. You just get in there and remove the bone-on-bone pain generator, removing about 2 to 3 millimeters of the distal trapezium. My next tip is if you're resecting bone, and it doesn't have to be just for this, for anywhere in the wrist, put a smaller burr inside a larger sheath. So in this case, is a 2.9 millimeter burr in the 3.5 millimeter sheath. And what that does is it leads to more space for egress of the bone debris and soft tissue debris, so the thing doesn't get clogged, which can be a big source of frustration if it's constantly getting clogged when you're trying to take this bone out. So smaller burr and a bigger sleeve. So you do this under arthroscopic guidance. Make sure you like the position of where you are. Remove the distal half or 2 to 3 millimeters of the trapezium. And then in the old days, we used to just pin these for 4 weeks. And in fact, we published on this, and these patients did really well with no bridges burned. If this failed, you could always go back to a LRTI or something different. But a lot of people didn't really like the pin, and so we went to a suture button construct, which I do for my open procedures as well. Here it is, an arthroscopic hemitrapeziectomy, but you could see at time 0, as I load the thumb subsides, but then we insert our suture button construct, and that gives immediate stability and starts and allows you to start immediate range of motion. And these patients are immobilized for a short period of time before they start therapy. And we published on our midterm clinical experience about 65 months follow-up. We're now publishing on our 10-year follow-up with similarly good results with good longevity. I always tell my people who argue against this technique, you know, if you rod a femur, you don't necessarily have to put them back into a cast. So if you're going to take care of a thumb CMC joint, you don't have to put them back into a cast. You just get them moving right away. So we're getting a little bit short on time. I could keep going on and on. Eric, is this a hard stop at 9 or?
No, it's not a hard stop. You can keep going for a little bit if you want.
Okay. All right. So I only have a couple more slides, I think. Scaphoid fractures, I think this is another good indication for use of arthroscopy. So this is, for me, a slam dunk for arthroscopic treatment of a non-union. I'll get to this more later. But this is interesting. You know, it's really popular worldwide. Here again are some of the publications of scaphoid fractures in arthroscopy and scaphoid non-unions in arthroscopy. And you can see the number of publications has really ballooned over the last couple of decades. And here are some of the people around the world who are who have published a lot on this and have shown amazing results with arthroscopic management. What's interesting, and here are some of the papers that have been published since 1995. But it's interesting that it's really not that popular in the U.S. and I always wonder why. And I think there's a couple of reasons. Number one, it's technically challenging. No doubt it's a little bit more of a difficult procedure to do arthroscopically. There's definitely a learning curve. The cases take longer to do, and so that means longer cases mean less cases, which means less potential earnings. And we have good open procedures. If we do an open, I think we have a lot of good ways of treating scaphoid fractures and non-unions via an open approach. So why consider it? And I do think there is potentially better healing because you're not stripping the scaphoid, whether it be open for a fracture or a non-union. You're not stripping all those capsular attachments and the blood supply to the scaphoid. We know that our primary blood supply is from a retrograde fashion, both dorsally and volarly, but there is these capsular attachments which provide some vascularity as well. And by doing this arthroscopically, I think you preserve that. And I do think that the healing rates are probably better. I would not start your journey of doing arthroscopic scaphoid fractures with this case. This is a transscaphoid perilunate. It looks dramatic, but and once you get in there with the scope, it often looks very intimidating because all you get is a big view of blood. But if you take your time with it, and here I'm using this wet just to clear out the hematoma. You take your time with it. This is from the radiocarpal joint. You can see the fracture right there, traversing across from the 3-4 portal. Then now I'm in the midcarpal portal and I'm cleaning out again some of the debris. I'm doing this wet, and you can see there's the lunate at 3 o'clock. In the center of the screen is the proximal pole of the scaphoid, and then in the background is the distal pole of the scaphoid. And you can see you get a great view of the fracture site. And once you clear out the debris, then you can reduce it. So what I like to do here is I put a 14 gauge needle, just like you would for an open repair, right next to the scapholunate ligament, just radial to the scapholunate ligament. And this is placed via the 4-5 portal. It's put right in the scaphoid. I get a fluoro shot, send the K-wire down part of the way, make sure I like it. I send it to the fracture site. Then I go back into the midcarpal joint, reduce the fracture. You can see you can't get a better look at your reduction than like this. So once you're happy with the reduction, then you can fire the K-wire the rest of the way down. And so you have your assistant put the K-wire down. You could put a derotational wire. We liked our derotational wire so much that we ended up putting an additional screw down that wire. And so that's what it looks like once it's done. After you remove your traction, put your screws in. And this is what the guy looked like at 3 months healed. What about scaphoid non-unions? Again, I showed this slide earlier. This is for me, a slam dunk right in the waist of the scaphoid where there's a little lytic lesion. You could argue that you could just bone graft that percutaneously and put a screw in. I'm not going to argue with that by any means, but some people would take this down, formally curette it out, throw in graft, then put your screw in, strip all those soft tissue attachments. And I think that might be a little overkill for this. And so I think that's a good case for an arthroscopic treatment. So we know there's a number of ways of treating scaphoid non-unions. This is, I will submit to you, the arthroscopic assisted is a good option. And this was described by the late, great Joe Slade in 2003, and a number of other investigators ever since. And again, it's one of those things where it was very popular. I'm sorry, it was introduced a long time ago, but again, why slow adoption in the US? Same argument for the scaphoid fractures. And for me, it was a life-changing when I met this guy, Pedro Delgado from Madrid, Spain. And I saw him do a live surgery on a live patient. He was demonstrating it, and he did this arthroscopically, very similar to this the case I showed, and finished it in about 30 minutes. It was really impressive. And it was live in front of an audience of about 200 people. So it was pretty impressive. So that for me just showed me I can do it. It just, you gotta be patient with the learning curve and give it time. And you'll have success. And so this is that case that I showed again. Nice lytic lesion right in the waist. Here you can see the traction tower. This one, I like to use this traction tower because it allows me to get the C-arm in to help me visualize my reduction. Here, the midcarpal view shows the non-union site. You can get a great view of it. And then you can see I'm just curetting out the central portion of the non-union. You can see the distal pole has good punctate bleeding, so you don't have to debride too much off the distal pole, but approximately I took out all the necrotic bone. And then I harvest some distal radius autograft right from the 3-4 portal, right from Lister's tubercle, and then I just plop it in right into the non-union site. Pretty simple. It's not that hard. And then once I'm satisfied with the filling of my non-union site, then in the tower, I just put my guide wire, just like I showed for the perilunate. And then once I like that, check it on X-ray, then I put my screw down, and that's what it would look like with the graft inside. Just a quick word on distal radius fractures. This is a whole nother talk. I'm not going to dwell on this, but I show these are my two partners, Rob Kamal and these are two of my colleagues. Rob Kamal is my current partner. Lauren Shapiro was one of our residents who is now at UCSF right up the road in San Francisco. She was one of our former residents. But they're they published a lot of evidence-based stuff, and I'm not going to argue that arthroscopy for the treatment of distal radius fractures is probably not needed. And they've published on that extensively. So this is a shout out to them. But I do use it in certain situations, particularly with die punch fractures or styloid fractures, where I want to elevate a die punch fracture. And I don't know that I can adequately do that via indirect methods with your volar approach. So I like to throw the scope in there and elevate those fragments. But again, there's a steep learning curve. You got to be patient with it. But I do think that you get better reductions with arthroscopic management. Okay, so I'm in the home stretch here. I'm just going to say that you can't give a talk and not talk about complications. So we did a systematic review about a decade ago looking at the complications of wrist arthroscopy of all the publications out there. Thankfully, it's relatively uncommon, less than 5%. I think the main complications are based on portal placement, either it be chondral lesions or chondral injuries to the bones when you're inserting your instruments, or nerve injury, as we talked about. You don't want to plunge with your knife. You want to make sure you protect particularly the dorsal branch of the ulnar nerve or the dorsal radial sensory nerve. I like to avoid the 6U portal. I know some people use it, but I think that's dangerously close to the dorsal branch of the ulnar nerve. Remember, spread down to the capsule, and beware of the structures. Even when you're suturing, sometimes you're done with the procedure and someone takes a big honking needle and plunges it down and closes your portal, and you grab one of the neurologic structures or the tendons that way. Remember, the joint spaces are small, so yeah, you don't have the same amount of space to drive around like the knee or the shoulder. So just be careful when you're driving the instruments around. We talked about the EEF probes. Again, you want to use fluid for that. You want to make sure you maintain the proper temperature and use it judiciously. And most importantly, choose your indications carefully. Obviously, if you're doing wrong procedure, that's going to be potential for complications. So to summarize again, my top 13 tricks, just to go over them again: spread judiciously when creating your portals, spread, spread, spread. Use your accessory portals as you need them. They're your friend. The poor man's arthrogram, where you inject into one joint and see whether or not the saline traverses to another joint to help confirm your diagnosis. Remember, an arthroscopist is like a pilot. You want to have your pre-flight checklist. So you check your focus, your inflow, your outflow, make sure your scope's in good working order before you start driving around. I always encourage you to follow the same sequence for every scope so that you don't miss anything, and that you make sure that you see and diagnose everything. If you're treating ganglia, try the methylene blue or indigo carmine percutaneously through into the cyst to help you visualize it arthroscopically. The bubble test, where you inject air into one joint and visualize on the other side to see whether or not there's any bubbles that pass through, which also help determine if there's a partial ligament injury. I think thermal shrinkage is totally fine in wrist arthroscopy, less so in the shoulder for sure, but definitely in the wrist. And that's mostly because you can immobilize the wrist for 6 weeks, whereas you can't immobilize the shoulder for 6 weeks. I showed my technique of arthroscopic TFCC repair, which leads to earlier range of motion and potentially no immobilization, or definitely not 6 weeks of immobilization. I think I would submit to you that microfracture for ulnar impaction syndrome is something that you consider, so you can avoid ulnar shortening osteotomy and for isolated osteochondral lesions. If you're going to burr down bone for whatever reason arthroscopically, use a smaller burr and a larger sleeve. That helps prevent clogging. I like to use a suture button suspension for my thumb CMC joint, whether it be done arthroscopically or open. It allows for immediate range of motion. And I do think there is a role for arthroscopic assisted fracture treatment, particularly for scaphoids and scaphoid non-unions, maybe less so for distal radius fractures, but I think it is useful as a useful tool, as a potential tool, and it helps improve your reduction and improve your healing. So finally, hand and wrist arthroscopy is a triumph of technology over reason. Here's a PIP arthroscopy. I do a ton of these. But you can argue that this may be a triumph of technology over reason, but hopefully over the last hour plus, I've shared a lot of other techniques where I do think that arthroscopy has a huge benefit in the treatment of a lot of these pathologies. So with that, thanks for your attention. Sorry for going over a bit, but happy to stick around a little bit if you guys have any other questions.
That was fantastic. Wow, quite the tour de force. I'm like blown away. That's awesome, Jeff. Thank you. Tom, Joe, our two fellows on. Do y'all have anything you want to ask Dr. Yao?
Just a quick question for you, Dr. Yao. Nice to see you again.
Yeah, nice to see you, Tom.
Question about how the order of operations for when you do scaphoid. So are you generally putting in your screws antegrade, and then any tips on kind of your reduction techniques? Typically, we will place our screws here at Emory volar percutaneously, and I'm curious as to how you negotiate the C-arm. Do you take them out of traction? Where you put your wires in?
Great question. Yeah, a lot of this is hold on. I'm going to try to go back. A lot of this is a learning curve for sure. So I'm just going to show you again. I don't have any financial relationship with this tower, but this is called the arc tower, which allows you to bring the C-arm in from either side. So the traditional, I do like the Linvatec tower, the so-called Whipple tower, the one that has the post right behind the arm. I do like that for most of my other arthroscopies, but for my fractures and my non-unions, I like this tower so that you can get your C-arm in, and you can definitely put the guide wire in volarly this way. Regarding your question about reduction techniques or tips, you basically put your guide wire in as you normally would, perpendicular to your fracture site. Start it in the more proximal fragment. So if you're going volar, then it's the distal segment. If you're going dorsal, it's the proximal segment. And then you advance the guide wire to the fracture site. Then you put your scope in the midcarpal joint. And then you saw me use a trocar. You could use a probe. You could use a Kleiner-Kutz. You could use a Freer retractor, whatever you need to do to reduce the fragment. And sometimes you could use the K-wire, the guide wire, as a joystick to joystick it down. and put it in the correct position. And then once that's in the correct position, then you and then once you're holding reduction, as I showed in the video, then you could fire the wire across, and that maintains the reduction. And sometimes your wire is not in a great position, and you use that as a kind of a pseudo reduction wire, and then you put another wire down exactly where you want it based on the position, just like you would do open. But you're just visualizing the reduction arthroscopically as opposed to relying on fluoroscopic imaging. Does that make sense?
Yeah, for sure. If you notice there is a huge humpback or a certain amount of bone loss, are there some cases that you know you're going to go open, or are you okay going arthroscopic for most of them?
Yeah, for sure. This is definitely still a journey for me. Like I said, my slam dunk is this case right here, where you have that there's no humpback deformity. You got that lytic lesion right at the waist. Otherwise, the architecture is well maintained. But this is what I was referring to earlier, is that a lot of our colleagues around the country, around the world, not the country, around the world, are doing amazing things arthroscopically, humpback deformities, huge lytic lesions, and just, and getting amazing reductions, amazing results, again, because you're not stripping everything to get that whatever hardware in to get your reduction. And if you put a plate on or a screw on whatever, PC Ho from Hong Kong notably will do big humpback deformities, correct it, and just put K-wires in. And just because he's got good bone graft, good biology, and stability from the K-wires, you don't need compression, you'll get a good result. Again, mostly because you're not stripping all those soft tissue attachments to gain access. And so I think that vascularity is critical to the healing. And so I'm not doing a lot of those, the bad humpbacks arthroscopically. There I will do an open approach, and I prefer for humpback a volar approach for those. But it's definitely being done, and this is what I meant. We're definitely behind our colleagues around the world for sure.
Thank you. Great talk. Great talk.
Yeah, thanks. Good to see you.
Doctor, yeah, thank you. That was awesome. Coming from a place in residency where we did not do any wrist arthroscopy pretty much, it's been really cool to see in fellowship, and it's definitely something I want to do as an attending. I at a very basic level, I was interested in, you said that the majority of what you do is wet scoping, right? So the majority of what I've seen here has been dry scoping, and I'd be actually really interested in hearing you and Dr. Wagner discuss the pros and cons of each.
Yeah, for sure. Yeah. Well, I'd love to hear Eric's thoughts as well, but I definitely think there's I think it's really just preference. I do think there are certain indications where you definitely want to use one or the other. I don't think you want to pigeonhole yourself into one technique or another. I can tell you that I trained under wet arthroscopy, so I feel very comfortable with it. Been doing it for over a decade, and I'm very, very comfortable with it. But that being said, I do think there's a benefit to dry arthroscopy, particularly for things like I showed when I was doing that non-union. I was doing that dry, so I was dropping the bone graft in dry for a number of reasons. Number one, that's a longer case. So as you're pumping fluid in, your wrist is blowing up, and potential issues with that. Same with like shoulder arthroscopy. Number two, as you're pumping fluid in there, you're potentially washing away all your growth factors that could potentially be beneficial for the healing. Now, that being said, I asked PC Ho this because he does all of his wet, and he doesn't care. He just dumps his bone graft in, the fluid's pumping through, it's probably washing away a lot of the stuff, but he's still getting amazing results. So I don't think you need to do it dry, but that's when I do it dry. Similarly for distal rage fractures, again, I glossed over that a little bit, but I do think there's a benefit for doing lunate facet depressed die punch type fractures. And I do that dry so that I get in there, I get my instrument, whether it's a elevator, a freer, a Kleiner Kutz, something to get in underneath and lift it up. I think there's a benefit for doing that arthroscopically. And I don't like to do that wet because, again, everything gets boggy when you ultimately do your definitive fixation. Everything's all soggy. But also, there's some concern about pumping fluid into a fracture where it potentially could cause it almost like an interosseous compartment syndrome. I've never seen that, but that's the argument against that. And then lastly, if you know that you're going to be doing something that takes a little bit longer, particularly, you know, the scapholunate capsulodesis, as I showed it doing it wet. But if you're concerned it take some time, then you again, you don't want to necessarily keep blowing fluid in there to blow the wrist up. So you could do that dry. But I do think there are certain situations where you definitely need to do it wet. Like, for example, we talked about the EF probe. You need to cool that down. I'm concerned about doing that under dry arthroscopy. So I definitely do that under wet arthroscopy. And then when you're debriding stuff, Eric may feel differently, but when I'm debriding stuff, I want that fluid to wash it out. If you're debriding it and then you got to flush it out, dry it up, then debride more. I don't see the necessarily benefit. But again, Eric, love to hear your thoughts.
Yeah, no, I mean, you hit on it all. I mean, I think there's some indications that it's like, I think it's for the most part surgeon preference. I think you hit on the ones. I think when you graft, at least from my perspective, it's a little bit easier to keep the graft in place. And so like the scaphoid onion, something like that, I think it's easier to disrace. If you're doing a combined sort of open arthroscopic cyst, I think it's helpful not to have fluid extravagate. But and if you're doing a long case, potentially it's helpful not to have it blow up. But for the most part, I think it's surgeon preference, Joe. I think there's there's honestly, so Joe and I did a CMC today, and there's certain aspects you saw us like constantly having to sort of change out the shaver, and as we're taking down the trapezium, that honestly, if we'd done it wet, maybe it would have gone a little bit faster. So I mean, there's probably certain aspects that I think are a bit easier wet, certain aspects are a little bit easier dry, and then I think ultimately it's your kind of ultimate preference. So as y'all have seen, I like to do a dry, but at the same time, you've also seen where we hook up the big 60 cc saline to our IV tubing, so we can sort of pump in fluid almost as much as we want. Jeff, do you have a pump, or do you do saline traction or gravity traction? How do you regulate your volume for wet?
Yeah, I usually use a pump set at 30 millimeters of mercury.
Yeah, sounds good.
But yeah, then you're in the, you have that, you mentioned the 60 cc syringe, it just sort of irrigates stuff out, and then you're going from dry to kind of that moist arthroscopy, which is kind of in between. But I'm just wondering, what are you, in your view, what is the main benefit of the dry arthroscopy? Because I do it for the fractures, but I don't know if I see the benefit. And it may just, again, be my preference biasing me, but the benefit for when you're doing TFCC or something else.
I mean, a smaller case, I'm not sure if there is a benefit. Like it's you can see stuff relatively well. I don't think there's like, you're once you're comfortable establishing visualization, I'm not sure if it adds a whole lot of time. But I think a smaller case, I don't know if there's a huge benefit, because you're not gonna have the extravagation. If you get to be a little bit longer case, then potentially making, if you do want to use accessory portals, it's a little bit easier to do it without having some of the fluid blow up or the wrist blow up a bit. If you're doing a combined open arthroscopic cyst or disc race, or maybe like if you're doing like a Burgage reconstruction or something like that, then it's maybe a little bit easier. It's not as much not as much blown up. So I think some of the it just depends. But I think the longer cases, I see a benefit. The shorter cases, I'm not really sure, unless you're talking about like scaphoid or a disc race. I'm not sure if there's, so I definitely can't argue that there's a huge benefit. This is kind of how I've done it for some time now, and do like it, but there's certain instances where I will do it wet, i.e. the thermal ablation. If I decide that that is the right answer for SL or for TFCC, then we sort of hook it up to a gravity traction fluid. So, but no, I think, I don't know if I don't know if I can totally sell you on that there's a huge benefit, Jeff. I think it's surgeon preference.
So when you go in, sometimes I get frustrated because I'm so used to a nice clear field with the wet. Sometimes you got a ton of bubbles in there. You got the articular fluid in there. Do you always do your automatic washout, or do you to wash that out, or do you just get used to driving around bubbles and just dealing with it?
No, I mean, I think one of the, and I've also seen this, but one of the cool things you can do is, instead of just dumping a bunch of water in there, as Guillaume Erzberg talks about a little bit, if you do that, you have to spend all the time like cleaning up all the fluid, or you can't see, as you mentioned, it's kind of this like boggy mixed zone where it makes it a little challenging. No, I mean, I think actually when you get in there, you can you can either use a shaver, or if you stop the shaver where it's open to suction, or you take out the shaver part of the shaver, then you can like suction and basically like just clean out. You have one part of the scope open, so that way it's not a vacuum, and you can basically suction out any fluid you in there, and then you just have dry arthroscopy, and you don't need really any fluid. So the only time we use fluid really is if we're like doing a hemitrabeectomy, or if we're taking out bone, or skip excision, etc. Like if you're not debriding out stuff, then I don't think you need a whole lot of fluid.
Yeah.
I know the fellows could sort of tell me if I'm lying, but I think there's yeah, for the most part, like I don't think you have to put a lot of fluid, and I actually get like a little frustrated if I get into the room and they are actually, they're probably early enough that they haven't done this, but like other fellows have put in a bunch of fluid in the water in the joint, and I get in there and it's like all this fluid. I'm like, guys, that's gonna take freaking forever to take out. Like, why'd you pump all this fluid in there? So there's the learning curve, I guess, to establishing a portal, and definitely when you get a bunch of water in there, as you kind of hand to that, it's kind of a pain in the neck trying to get it out.
Yeah.
So.
Yeah. Cool.
Yeah, that's awesome, Jeff. I have to ask you one question before you go. You've done all this amazing stuff. You've pioneered all these things, and from as you kind of hinted at, from an American standpoint, I mean, you have been the innovator or pioneer of our generation of arthroscopy. So, what is the next step for you? What's your next innovation? What's your next what are you next excited about in wrist arthroscopy? What's the next thing you're really excited about?
That's a great question. I think we really need to work on getting our instruments better, our instruments smaller. There's definitely some work being done on that, because there's certainly a limitation of what we can do based on the instruments that we have. But there's going to be a plateau in terms of how much we can do there. Obviously, almost every pathology in the wrist has been thought about, and thought about whether or not it can be treated arthroscopically. I think there are potentials for endoscopy, something I've been working on, which I haven't been able to quite figure out, and maybe you can, or one of your really smart fellows can work on, is I'm trying to do denervation endoscopically. So potentially, sometimes you have a dorsal wrist impingement, or somebody's got dorsal wrist pain, you want to just do a PIN neurectomy. I can back the scope out from the 3-4 portal, bring it completely vertical, and go right down into the 4th compartment. I see the extensor tendons really clearly. I see the PIN sitting in the floor. I just can't figure out a way of safely removing it or ablating it. So we looked at double barrel scopes, which do exist, but not in that size. We looked at potentially double, scope coming in retrograde and an instrument coming in antegrade, but haven't really been able to figure that out. But I think there's some benefit to that. But then again, you reach a level where is it a triumph of technology over reason? All right. Are we doing endoscopic trigger finger releases or endoscopic deconvergence releases? Is that really a benefit? Or are you just doing it just to say that you can do it? I mean, we could talk all day about endoscopic carpal tunnel and all that stuff, but I do think that there is a benefit in terms of healing and stuff like that for particularly the scaphoid non-unions, and that's one of the more recent things that I've adopted, because I was a little bit intimidated by the learning curve. But I think you can just keep pushing the envelope in terms of the ones that you can treat arthroscopically, as opposed to doing a big open whack, all that soft tissue stripping. So I definitely think there's improvement there.
That's awesome. That's something, I saw that present at the ASLH thing in Brazil. I saw this person present on doing the ECU tendonitis endoscopically, I guess. And it was a cool presentation. So I don't know. Yeah, I agree.
That's a debridement, or
yeah, it basically came through like the little recess in the ulna, found the EFCG, and then did debridement. So kept the subsheath intact and kind of debrided out with the ECU. It was interesting. It was a very beautiful video they had. I don't know. I have never done it, obviously. But it seemed logical because, when I've done most ECUs you can treat non-operatively, but the ones that are TNS device that don't respond to everything you try, I mean, then you're taking down the retinaculum and taking down the subsheath, and it's just like a lot. So there is some attractiveness to that. Now, I have to admit, I'm not sure if I see enough of them play around them much, but it was a cool idea, cool video. So
Cool.
well, awesome, Jeff. Thank you very much. Really appreciate you spending your evening with us. And yeah, I'll see you at HS as well as you. My schedule opened up a lot, so hope we can grab a
Yeah.
beer.
I decided not to change my flights. Why not spend
Yeah.
an extra day in the Bahamas, right?
Me too.
All right. Well, it's great to see you all again. Thanks for staying on. I know it's late for you guys over there, but I appreciate the great questions and the interaction, and hope to see you all sometime soon.
Awesome. Thank you.
Thank you.
Night,
All right.
thanks.
Take care.
Thank you.